the rise of the cases post-COVID or post, I think the autoimmune cases and the arthritis have increased quite a lot. And a lot has to do with a little bit awareness among the patients, thanks to the Google and other applications, that they tend to approach the specialist doctors quite early. But joint pains definitely are, as Pavan sir said, it's very confusing. It could be a sign of something which is going on inside. It could be a sign of anything inside. So, as Dr. Helen had pointed out, arthritis just means joint inflammation. Just like we say for fever, we need to look at the reasons. Maybe for fever, we look at COVID, dengue, malaria. So when a patient of arthritis does come to us and they say कि नहीं सर दवाई लिख दो, we always say कि नहीं पहले reason at least ढूंढने दो कि क्या है. Giving painkillers and steroids is not going to solve your problem. So there are around 200 diseases and some other specialty diseases like oncology diseases which can even lead to the joint pains and arthritis. So today I've just tried to keep a little case-based presentation. So at least we come across a lot of cases which we see and how do we approach in them and where we can in a busy clinical practice, how we can within 5 minutes just at least screen our patients. So at least we can minimize the investigations also and come to a good diagnosis. So as we were taught in MBBS, and still it is the main thing, history is still our key. For most rheumatologists, and as our seniors also always pointed out, that take a proper clinical history, because a history will give you a very fair idea that which disease this patient is suffering from. Almost 60 to 70% differential diagnosis is just from the history. It's like a pediatrician can just tell from baby's cry what kind of the ailment they'll be suffering from. Same way a rheumatologist has to diagnose just from the history what exactly they're heading, because the test can have a lot of falsies. They may be positive in some, negative in others, and patient may still be having all the symptoms. Especially with this new packages of health checkups coming up where everybody is RF factor positive, it always gives, there's a dilemma who to start the patients with or not. So history and examination almost forms 90%. Labs are just 10% supportive. And mostly it has to be a preclinical probability which we say that why are we advising these labs in a patient? So that's why we need to be sure that why we are advising the RF factor, ANA, ANCA or any other test on the basis of our clinical diagnosis. So that way we don't land up in a soup that what if it comes positive or what if it comes negative? Where exactly are we heading that way? So whenever the patient walks in, first and most foremost thing is just look at the gait they walk in. That will give you a fair clue that what exactly is wrong with the patient. Maybe he's having an osteoarthritis of the hip, osteoarthritis of the knee, or a swollen joint. So a gait will definitely be able to help you delineate what exactly is wrong with the patient. Maybe it's a case of myositis. He may not be able to get up from the seat. So all that is very important when the patient walks right into the cabin. Now, first and foremost, it's always better when we take the history, mystically distinguish are we dealing with a joint pain or are you dealing with some soft tissue problem? Soft tissues are much more common in our clinical practice because of the lifestyle and the other problems than the arthritis. So this way we'll be able to very delineate and we don't need to advise too many tests if we are dealing with a soft tissue problem. For soft tissues, we do have tendons, bursa, muscles. So I think all those, most of us who play sports, we know all these things can get injured, like the tennis elbows, supraspinatus tendinitis, dequerens. But in clinical practice, how do you distinguish? Is basically then articular will have a pain both on active and passive movements. We know like a rheumatoid joint which is swollen, patient may not even be able to move the joint. But that may not be the case when it's a dequerens. Patient will be able to move, but only during that certain motions it will be painful. And there'll be a focal point tenderness. Say if you are dealing with a tennis elbow, you may find a tenderness near the lateral epicondyle. Limited range of motions. And swellings is a very particular sign in articular conditions, which may or may not be seen with non-articular conditions. And deformities again happens with articular. The non-articular, no matter how painful, how much swollen, may not cause a deformity or a crepitus. So it's very important from the basic history and always we take a history that what exactly triggered your pain. A patient with a tennis elbow or any other complaint like a soft tissue will definitely have some history that I lifted something heavy, I closed the door that way, or some other history they will give. So that at least helps you distinguish that yes, it's a non-articular. And I think these are all the non-articular conditions which more or less we all keep on suffering from as well, and most of them we keep coming through our daily life as well. Why is it important now to distinguish non-articular? Because these are the patients you don't need to put them on very heavier medicines. A short course of NSAIDs with I think the physiotherapy, cold sponging, all that is okay to go with, and they get better with that as well. And musculoskeletal ultrasound is a new modality which has come up in our clinical practice, and it helps us to distinguish and identify those structures very quickly. So soft tissue injections are very useful if you find a tennis elbow not responding to 15-20 days of medical treatment. And now the PRP injections are also coming up for that part. So that's why it's important to distinguish right at the beginning. Are we dealing with articular or are we dealing with the non-articular? Little history and physical examination will give us a very good clue. And if we still have a doubt, always an ultrasound or an MRI of that area. And ultrasound is still a cheaper modality. And that's why it will help us delineate where we are dealing with. So now coming to the more important aspect, the arthralgias and the arthritis. So arthralgias are just vague pains which can be again attributed to many reasons. As we go further, I'll delineate all the causes which can come with arthralgias. Arthritis is basically joint inflammations. As our pathology book said, the five cardinal signs should be there. That is your pain, redness, swelling, warmth, fluid accumulation, and especially early morning stiffness, which is very typical in the arthritis patients. And especially that stiffness should be lasting more than 45 to 50 minutes. And few of the non-inflammatory causes of arthralgias can be osteoarthritis. And definitely the metabolic profile is something we shouldn't overlook, be it the thyroid disorders, diabetes, calcemia, and always have a drug history, especially the patients who are taking the tuberculosis medicines. Any patient who's on levoflox or any quinolone for a long time develops a lot of tendon pains and which may be very severe. You may not find any signs on it, तो पेन का इतना सिवियर रहता है they keep complaining they're not able to do any activities with that. And fibromyalgia, obviously, it's another cause which has been recently defined quite well. So just a simple case. This was one of the first cases when I started in Medanta. That was almost 10 years back, and she came to a patient with emergency, and she came with multiple joint pains and lethargies. It was a history of weight gain was there. Obviously, we could not demonstrate much of the synovitis that time, but she only had one knee which was quite swollen. There was not much of a morning stiffness, but she had signs of numbness in the hands, which typically worsen in the nights, giving suggestive of a carpal tunnel syndrome. So we did all the workup and everything, and most of the inflammatory markers kept on coming normal for her, but she still kept complaining there's a lot of pains, a lot of stiffness that night. Since we did the further workup, there was a proximal muscle weakness and delayed ankle jerk as well. So only finding which we found here at the latest, because we sent the profile next morning was the thyroid profile, and the TSH was extremely high at 26.4. This is one of the first cases we saw which presented with polyarthralgias. Unusual finding was a left knee swelling, and that came out to be a hypothyroidism with a bilateral carpal tunnel syndrome. So these were just vague arthralgias, no synovitis. And once we look at the inflammatory markers, they are normal. We need to suspect that there is something else which may be going on. Obviously, there can be a little falsies in this, but at least they give you a basic idea that yes, it may not be inflammatory altogether. As this is a typical case, I think a lot of people do see in the OPD, especially in the females which come through. A 36-year female came with multiple joint pains and lethargy, and she kept on saying there's a morning stiffness of 20-25 minutes, and she feels the whole body is swollen. Disturbed sleep is there, and she keeps getting frequent headaches, irritability, forgetfulness. But there was no weight loss, appetite loss despite all the stress. And she has been to multiple specialists all throughout. She used to get benefit from some painkillers, some steroids here and there she took, partially benefit, but moment she stopped, the pain kept coming back. And n number of tests were done for her, but nothing much was getting found. So when we did examine, we found there was not much of a synovitis which was seen. There was tenderness in all the joints, along with tender points were there. The NSAIDs, as we see, very good response in the inflammatory. We did not find much of the response in these patients. Eventually, we had to formally form the diagnosis as fibromyalgia. Definitely, a lot of there's still controversies on this diagnosis. A lot of people still don't believe that this disease exists, and it's mostly put in as a diagnosis of exclusion that you have ruled out the endocrine causes, you've ruled out the inflammatory causes, you've ruled out the chest X-ray and other things. There's nothing much found. Then only we are able to label this patient. And this has been very well now defined. There's a third type of pain which has been defined now. Initially, there were only two pains, which was the nociceptive, which was like a tissue damage pain or a neuropathic. But the third pain, which has been defined as nociplastic, when there's a central sensitization of the pain, but there's no damage to any tissues, nerves, test, everything comes out to be normal. And definitely, we see much more in females for reasons there because of the stress of the family, the trying to cope up with a lot of things. Definitely, very few males we find with fibromyalgia category. So, females with no findings, blood test normal, screening normal, this is where we need to suspect them. And little bit of counseling along with a little bit of medications. We do promote yoga and meditation for these patients. Definitely helps them go a long way. So just to summarize, when you do see a patient just who has a joint pains, definitely get first of these markers done. The thyroid, hypercalcemia again can be a cause of a lot of joint pains. Always rule out with the creatine phosphokinase because patient may have an underlying myositis and it may present with joint pains and muscle pains together. Vitamin D and B12 normally we do mostly in all patients. Again, blood sugar and ESR-CRP. If ESR-CRP are definitely high, then you need to go further and look for the other causes of autoimmunity or for any inflammatory pathology which may be hidden inside. Now, coming to the more dreaded topic, that's the arthritis. The synovitis, that is the tenderness plus swelling. So now we approach a case of arthritis. So whenever a patient does come in OPD, we always look at what is the pattern of the joint involvement for the patient. Because that is one of the most important feature which will help us advise our test and do the further management. So it is a monoarthritis that's two to three joints, or it's a frank polyarthritis. All the causes may differ a little bit overlap or an unusual presentation of a disease, but at least we don't go. And then it's an acute and chronic. It's an acute and definite.
I think there is some technical glitch from the speaker side. There is some technical glitch from Dr. Naval's side. Probably he'll be joining in a short while.
Sorry, I think it got disconnected. Is it visible now, sir? Can you continue? Just so this is basically a case of monoarthritis which we were discussing. Sorry, got disconnected in between. So this patient had a high inflammatory markers. So now exactly what is the approach we do in a patient of a monoarthritis? We feel it's infective, or if it may be there's no history of surgery or any arthroscopy done. So when we look at a case of monoarthritis, you have to distinguish is it inflammatory or is it a non-inflammatory like an osteoarthritis or like a hemochromatosis. And then we look at the inflammatory. These are the five main causes which can present like with a single joint involvement. It could be infectious, it could be gout, it could be tubercular, reactive arthritis, or a juvenile idiopathic arthritis. So for differentials in our patient, we made it down to infective etiology versus gout because his uric acid was high at 8.2. Could be tubercular and reactive since he had some history of fever which was ongoing. He did give a history. He had traveled to Thailand 3 weeks later, 3 weeks back, and had a definite contact with a sexual worker as well. So to approach this case, so reactive arthritis definitely has to have no fever at the onset. Just like we talk in GBS, a patient may present with the polyneuropathy without, but the fever has to be absent. Same way goes with reactive arthritis as well. Tubercular definitely not a very acute presentation. So since it's 7 to 10 days only, so definitely we can rule that part out, but definitely it's not complete exclusion as well. So definitely leaves us to infective versus gout etiology. So monoarthritis, only strong indication for synovial fluid analysis is a single joint involvement. And that's what I think we do with this patient. If it's a polyarticular, we normally don't do the synovial fluid analysis in those patients. They do can be done with the blood test itself. And this is a typical picture in a synovial fluid. A bacterial and a gonorrheal infection may show counts more than 50,000. Tubercular and inflammatory are very overlapping with the counts of 5,000 to 50,000. Osteoarthritis is at 2,000, and crystal arthritis, again, since it's an inflammatory, mainly presents between 10 to 15,000. So anything more than 50,000, you have to suspect either bacterial or a fungal infection for that. So this patient had a counts of more than 1 lakh with a gram-negative organism which was grown. And then definitely it was a final diagnosis of gonococcal arthritis. Again, a clue was is the dorsum of the hands which was swollen. It can cause a tenosynovitis along with an arthritis. So suspect a bacterial in a mostly a case of a monoarthritis, single joint involvement with fever. Otherwise, it's very unlikely for a bacterial infection to cause a polyarticular involvement unless the patient is severely immunocompromised. So most common cause still remains a gonococcal for causing a septic arthritis. Staph is the next cause common. Another few of those diseases, but these are the two most common which we look at. If a patient is post-surgical, again we need to look at either streptococcal or Staph aureus for that matter. Now, coming to polyarthritis, it could be acute and chronic again. So we have a lot of causes for acute. I think most of us have dealt with the viral illness, serum sickness, drug-induced, any connective tissue disease, or most of the chronic diseases like rheumatoid, connective tissue disease, MCTD. All of them can present as an acute presentation as well. So definitely next come when you're dealing with a polyarticular, what is the pattern of the joint involvement? Because that will give you a very easy clue that what kind of disease you may be dealing with. So now this is a very common picture from which is from Harrison itself. And this is very commonly shows. And mostly what we are looking at here is the DIP involvement here. And DIP is basically only in 4 to 5 conditions which we'll see. And that is reactive arthritis, psoriatic, sarcoid, multicentric, and osteoarthritis. So a lot of times patients we do see of osteoarthritis, which patient a lot of times gets confused that may be having a rheumatoid. But you have to understand rheumatoid will never go to these DIP joints. Neither does the SLE, neither does the Jogren's. So a lot of times if you have some nodes coming out from the DIP joints, it could be the Herberdens nodes, which may be osteoarthritis. And now the inflammatory osteoarthritis has been defined recently as well. So this picture gives you a very fair clue that what exactly is the joint. Again, you have a CMC joint. Again, you do not suspect rheumatoid in these patients again. The wrist can be, and most of the joints can involve the wrist, so that is a very common. But for DIP, CMC, at least you know, narrow down your diagnosis. Again, psoriatic is a very confusing disease as with rheumatoid, because a lot of patients may not have psoriasis at the onset, but they may have the joint pains which are very typical either of rheumatoid or osteoarthritis. So always ask for a history of psoriasis in any patient you see the DIP joint involvement. And lower limb joint involvement again is seen in very few conditions. So if a patient just comes to you with knees, ankle swelling, and especially in this season, we see a lot of patients coming with ankle arthritis, definitely start suspecting sarcoid. Last week also we did have a patient who came just with ankle swelling and some few of the lesions on the skin, and it eventually turned out to be an overlap between sarcoid and the tuberculosis. And spondyloarthritis, gout again never starts from the upper limbs. Gout always starts from the lower limb, especially the toe or the foot joints. So intermittent arthritis is another very tricky situation because a lot of times patients will come to you with some intermittent history of joint pains. So today I'll just highlight on palindromic rheumatism because these are the patients which do get lost because they don't reach the exact diagnosis because the symptoms are very varied in them. So gout we know again is intermittent, but gout patient will always reach to you, and same goes with reactive and pseudo gout. But palindromic rheumatism is a very still quite a confusing scenario. So what exactly goes wrong in palindromic rheumatism? So a lot of times patient comes after few years of history that yes, today I had a right shoulder frozen, and he took some medicines. He thought he did something heavy, it got better. Yes, next time after a week or two, he says my left shoulder is swollen. And again, that gets better. Then he says, my right elbow is swollen or left elbow is swollen. So this is a migrating pattern which keeps happening in these patients. So by the time they reach a physician, because some patients just have an episode of 1 or 2 days, the episode is completely disappeared as well. So this is, I always tell my patients, and just like Kader Khan in that Bol Raha Tha Bol, he said, आज आंख बंद है, आज कान बंद है, आज ये बोल नहीं पा रहा. So same way it happens in these patients कि आज shoulder नहीं उठ रहा, कल elbow नहीं उठ रही, कल knee jam हो गई. So this is the pattern they keep behaving, and by the time they reach us, they do not have any symptoms, so we are not able to pinpoint what exactly is wrong with these patients. So this is why we have to we when we take a history, we always ask that you do you have a migrating pattern or is it like a static? And when you dig into the history, they are able to tell हाँ कि आज shoulder जाम हुआ, 2 दिन तक नहीं हिला, मैंने पेन किलर खाई, फिर ठीक हो गया और next day ये जाम हो गया. So it can be a brief attacks of mono or polyarthritis, more than 5 attacks in last 3 years, last for hours to 7 days as well, and at least one attack should be verified for the physician. That is the definition which the international council says that if these are the criteria which are fitting in, then you have to deal in a figure out in these patients. So labs at this stage, we do get a rheumatoid factor and anti-CCP done. Now, why is it important? Because palindromic rheumatism, some patients may not need a treatment at all. They just get better without any much of medicines, especially for rheumatoid factor anti-CCP are negative. 50% may phase out and 50% do develop. So in my practice, whenever they are positive, then only I start them on a regular treatment. Otherwise, I just tell them just maintain a diary of attacks. If the attack starts to increase, you then come to us and we'll start you on DMARDs. If you're getting one attack in 6 weeks, 8 weeks, subsides with 1 or 2 NSAIDs, then you don't need to worry too much. Because since the inflammation is not long in this joint, it will not damage the joint at least. So we do know that these are the patients who are not at a risk of developing joint damage at least here. Now coming to the next symptom which we see in our arthritis, always the back pain. Now back pain is a very miscellaneous entity. If it goes to a neurosurgeon, they may find a different diagnosis. If it goes to an orthopedician, they may find a different diagnosis. A rheumatologist will always try to find the ankylosing. So a basic approach to back pain with just few history, we can help at least delineate where we are going with. So we do know that disc pain, muscle pain, ligaments injuries, all can cause back pain, which I think all of us have gone through once or twice in the life. And the inflammatory back pains, which are the more troublesome ones. So this is a very classic picture of an ankylosing spondylitis patients. So we do ask for the back pain. Always ask, do they have the night pains or the day pains? It will be a very young male who will be typically in 20 to 40. And alternative buttock pain it starts with. Again, as I pointed out in palindromic rheumatism, same way the ankylosing spondylitis patients behave. They don't have a very regular pattern. They may just have one episode today. It subsides in 4 to 6 weeks with some painkillers. He may not even approach a doctor because the pharmacist gives them himself the painkillers. And this sequence keeps repeating over time till it starts to become a persistent scenario. And they have a very typical symptom of early morning awakening at 3 4 o'clock with morning stiffness. And definitely, as contrary to the disc pain, which gets worse with activity, a back pain always improves with activity and worsens at rest. So these are the very few questions if we can put in our scenario, at least we'll know that this patient may be the start of an ankylosing spondylitis. Because if we don't treat these patients, this is how they become over subsequently over next 10 to 20 years. So back pain in arthritis with joint pains, always suspect for ankylosing, again psoriasis. Enteropathic arthritis like the ulcerative and Crohn's can cause independent back pains with them. Rheumatoid again does not cause a lot of involvement in the lower back. It's mostly the neck which is more involved. So a lot of times you may find a positive RA factor with the low back pain. So that RA factor has no significance here. So we do not advise any labs of RF, NTCCP, ANA or ANCA at this stage of a patient with back pain because if false positive will just confuse you more. So just keep it limited to 2 3 tests, that is an HLA, a CRP, and if you can possibly do an MRI of the sacroiliac joints with lumbocervical spine screening. So a lot of times we find that lumbosacral has been advised, but the SI joint is often overlooked. So whenever we do advising in a young individual with backache, always make sure the SI joint is also looked at so at least we don't miss the diagnosis there because a lot of times SI joints may be inflamed without causing any symptoms as well. And if the patient is just poor, we can always go with an X-ray or X-ray of the dorsolateral spine because that is the first place where changes would have happened in a long-standing disease. But no RA factor, no anti-CCP, no NA. So now back pain with any point of arthritis, always look for ankylosing spondylitis group because this again may be very disabling in for the patients. Now going to the more important topic, since now we have the season, rainy season also starting, where the fever and rash will come with arthritis. So there are very few causes when we call it fever with arthritis, and we do have to delineate which how high the fever is, which can go with. Adult onset Still's disease, again a diagnosis of exclusion, but can present with a very high fever with joint pains as well. And sometimes it does not even cause joint pains. It can just keep on throwing fever and rash and body aches as well. SLE, lupus, we all know, but mostly presents with a low grade fever. Bacterial, that we just discussed, and same goes with viral hepatitis, that is the serum sickness it can cause. And itself, viral arthritis can cause small joint involvements. So large joints are normally not seen. Dengue, chikungunya, post-viral. Last year also we came across a virus where patients started having a lot of joint pains post the virus, infective endocarditis, vasculitis. So all these are a few causes of fever with arthritis. So we just have to delineate, are we dealing with an infection or are we dealing with some form of inflammatory condition? So this is a case of a 55-year-old female. She came with complaints of multiple joint pains. She had history of 2 weeks back fever with body ache, which subsided after a short course of antipyretics, with morning stiffness of 20 minutes. So on examination, we found there was tenderness and there was mild swelling also in the MCP PIP joints. But system examination was completely unremarkable. And she had a brief elevation of ESR, CRP, rheumatoid factor, which was positive at 48, the normal being 14. Anti-CCP and other things were normal. So what exactly are the differences when we come to this case? Because this is a very early stage of a arthritis, 2 weeks onset, and she does give history that there was some form of fever as well. So considering the scenario which we live in and the season which we see the patients through, so post-viral arthralgia definitely remains a possibility, but she does have some swellings as well. Reactive arthritis again a possibility, or it could be a start of an early RA since we have a rheumatoid factor positive as well. So what do we do next in this stage? Do we start NSAIDs and observe, or we give her steroids or DMARS, or an intramuscular steroids for a couple of weeks duration? So first and foremost, I think my observation was we gave her steroids and we gave her NSAIDs and observed for next couple of weeks. Again, it's since it's an early stage, we don't need to panic too much because rheumatoid arthritis will not and lead to damage to the joints till at least 4 to 6 months of disease. So rather than rushing through with the predominance of history, we can just observe for the patient as well. And then she subsided after 4 weeks, and now patient is in remission. So that RA factor, which was positive at this stage, was just a false positive value, considering she had a background thyroid as well. And we did not need to follow up the patient, and since being quite some time, she's been still doing quite okay. NT-CCP definitely has a more relevance than RA factor. So whenever we find an RA factor positive, always get an NT-CCP also done. So this was a case of post-viral arthritis, and I think in the coming season we'll be seeing quite a few of them. And since last year we've been seeing quite a lot of them, which has still not been going on through. So there's not much role of hydroxychloroquine, which was given initially. We definitely go with a short course of steroids intramuscular if needed at this stage, because it sends the disease in complete remission very quickly. So coming to this case, this is I think quite a typical case, and this will just point out that how if we don't catch these patients early, it can lead to a very dreaded disease this way. And since that's why sometimes just simple joint pains and swellings can be signs of something sinister, it can be signs of something which is coming through. So 24-year-old female came with multiple joint pain swelling with morning stiffness and oral ulcers. She did have history of photosensitivity. She had history of alopecia and two pregnancy losses. But as the goes, she was constantly taking some form of the NSAIDs from here and there. Because she belonged to some rural area where the diagnosis was not coming through. There were limited labs facility. And this disease kept progressing over the next 1 year. So when she came to us, we had seen there was a tender swollen joints. There was a typically malar rash which was present with lymphadenopathy as well. Systemic examination showed mild of decreased air entry at the bases, and there was tachycardia. A CBC showed a leukopenia as it was 3.6. So leukopenia definitely in a CBC will give you a very fair clue that yes, there's something definitely wrong. In an inflammatory state, definitely you expect something TLCB to be high or leukocytosis. But one of the conditions which can cause low TLC is all the connective tissue disease, be it the so ESR was 85, CRP 20, and her albumin had dropped to 3.2. We could have thought it's a non-inflammatory because of negative inflammation. The urine routine had now started showing protein 3 plus and RBCs 20 to 30. The further workup we did, her ANA was strong positive, serology was positive for SSA, SSB, Rho 52, hypocomplementemia was there, and she had a lupus anticoagulant positive and 24-hour urine protein had showed 1.8 grams. Luckily, her creatinine was normal at this stage, but this was a very sign that patient who started just with joint pains eventually ended up developing kidney involvement within that 1 year span of time where it could not get diagnosed. So it was a case of lupus with the lupus nephritis with the possible APLA since she had history of miscarriages and a lupus anticoagulant positive. So this has been the new criteria, slick criteria for lupus, which was changed. So whenever we do look at a patient with joint pains, we do need to look at the skin involvement as well. And oral ulcers, again, very typical patients will say that there has been multiple oral ulcers, aphthous, and they keep healing and going. A lot of times they keep doing taking Becosol, taking something, but it may be a sign of something which is starting inside. Alopecia, again in females, which is extraordinary, has to be looked at. And now they have included the complements, Coombs test, and other dsDNAs as an immunological phenomena. So the criteria changed a lot, especially the leukopenia, hemolytic anemia, again can be all signs of lupus. So we do have, with Rahul, I've seen a lot of patients here in Rahul Bhargav. So a lot of his patients started with ITP, over 5 to 6 years, they developed a full-blown lupus with a kidney involvement as well. So again, this is for all ITP patients. That's why we do run an ANA and an ENA profile as well in our center. So I'll just quickly point out some of the spotters which we can see through in our clinic. So this is a very typical of reactive arthritis, that is the circuit balanitis and keratoderma. So whenever you see these conditions, it has to be suspected that may be a start of a reactive arthritis. Plaque psoriasis, again, as in beginner of psoriatic arthritis. But psoriasis is something a lot of patients and they think only the dermatologist should know. We don't need to tell our physicians or rheumatologists for that part. So we always dig in with the history when we find that something is atypical or just ask for the skin history in the family. Because first degree relative with the psoriasis can be a marker there. And these patients may be completely seronegative as well. Because giving hydroxychloroquine in these patients may be a flare of the underlying skin problem, which may not be seen initially. So always ask for history of psoriasis or ask for any previous skin treatment they have taken. Aphthous ulcers, again, they are very typical and very particularly patient will say 3 to 4 ulcers. Single ulcers, mostly we do ignore thinking it's deficiencies, but if it's a multiple, especially involving the upper palate and the inner cheek, that is what we have to consider. It's some form of inflammatory. So lupus is one of the conditions which can cause Behçet disease and Crohn's. So these three are the most important causes for any patient developing recurrent aphthous ulcers. And these are very typical signs of a myositis disease, that is the heliotrope rash seen around the eyes and the Gorton's papules. So again, the basic examination on these sites will give us a good idea that yes, this is the developing of myositis again. And EN lesions, again, we have been seeing a lot of cases. This is a good spotter as well. A patient developing EN and we did a chest X-ray because obviously patient asked that lesion to sir वहाँ पे आप chest X-ray क्यों करा रहे हो? And that's where we find there was a mediastinal lymphadenopathy. And when we did a HRCT, it was quite a lot of lymph nodes along with ground glassing. So this is very typical of sarcoid, but definitely we need to rule out tuberculosis in our population as well. It can again present with EN, and you may find it some different thing altogether. As I said, I had a case last week of arthritis, came with right knee and both ankles swollen, and then the EN lesions came. But when we did a bronchoscopy, we found there was a mycobacterium tuberculosis in the lesions there, the lymph nodes. So arthritis with ENs has a very close diagnosis. Most common is definitely post-streptococcal. Patient may have had cough, cold, and develop these kind of lesions as well. Lupus, ulcerative colitis, again quite common. And tuberculosis definitely can never be missed out because we cannot start steroids on these patients till we are very clear what we are dealing with. And these are again the psoriatic nails, which we will look at. And tophi, definitely we don't see much in Indian population, the tophi, that is the uric acid crystals, but they can form at unusual sites and we have to distinguish it from rheumatoid nodules as well. Mostly we do get patients from Iraq and Africa. They do have a lot of these tophi which are developed there with them. And any lymph node parotid enlargement, definitely look at Sjogren's. Again, we do find a lot of delays when the patients with parotid enlargement comes because a lot of times they're treated with antibiotics or it's suspicion of a mumps. But most of the times it is the start of Sjogren's syndrome for them because over the years, any recurrent parotitis has to be looked at. Sarcoid again can cause both parotids involvement. IgG4 disease, which has again gained quite some importance in last few years. And HIV should always be excluded in these patients. Mumps definitely is a possibility, but we normally don't suspect if a patient is having a recurrence of episodes. And this is very typical of a group called spondyloarthritis. So if you see this, you cannot miss the diagnosis. These patients may have one or two joint pains, but this is a typical called as a sausage digit or dactylitis. So a lot of times in West also when the patients do come in cold, they don't remove the shoes, but obviously do see for these signs. Once you have this diagnosis, you know it's mostly the spondyloarthritis group you are dealing with. And just I'll conclude with the last two cases because these are again very miscellaneous cases and they need to be sorted out early because they are again very life-threatening ones. So a 48-year-old male come with fever and cough since last 1 week. He had joint pains and swelling which started from last 3 weeks. Took some treatment, did not improve. Followed by he started developing recurrent nose blocks, epistaxis, and even hearing loss, which happened over there. Started having lesions over the skins. So from the picture, we can easily say that this is the typical small vessel vasculitis. We don't even need to do biopsy because biopsy definitely will show the same that this is a leukocytoblastic vasculitis which is going on. But then again, is it the start of just a simple disease or it's something dreaded we are looking at? So when you do see a patient of any of with small vessel vasculitis and joint pains, look at for the HSP, which is again very common in our population. Cutaneous, which could be an independent, maybe drug induced, or just a simple vasculitis. ANCA and cryoglobulinias. ANCA is something which we cannot miss because within a week it can just completely disrupt the patient, destroy the patient's whole this thing. So this is something we need to do. So basic is whenever you see this patient, get a chest X-ray done. So this patient had multiple cavitating nodules which were seen through. And we did the further test, but within 3 weeks, you see he had developed a saddle nose deformity as well. The C ANCA was strong positive, CRP was quite high, his urine had started showing the RBC cast and proteins, and kidney biopsy we did showed the gastric glomerulonephritis. So simple case who started just with fever and a little low grade fever followed by joint pains. Within a week or 2 weeks, he started developing completely renal and kidneys and lung involvement. So this is where somewhere highlighting the joint pains, looking for the more robust markers will give us a lot of importance that yes, these are the patients. If we diagnose them early, we can salvage them early. नहीं तो ये बिल्कुल ही within 1 2 weeks they are completely on a ventilator also. We have seen such cases as well. So final impression was granulomatous polyangiitis, and we must do a chest X-ray for all these patients. And any patients which comes with small vessel vasculitis, I always get an ANCA done. Even he may not have much symptoms, but at least we need to be sure that he does not have the dreaded disease as well. And I'll conclude with the last case because again, this was one of the very eye opener for me, and it happened 3 4 times now. So that's why we are very particular in these cases. So it was a 16-year-old boy who came with multiple joint pains and swellings, complete with low-grade fever. There was loss of weight, loss of appetite. He had a high inflammatory markers of ESR CRP, but rest of the markers were all negative. So he was labeled as a seronegative juvenile idiopathic JIA, which was seronegative variant, and started on hydroxychloroquine with steroids. Patient felt better after 2 weeks and then was referred to us for addition of DMARDs, considering it was a 16-year-old boy. So we did find they were both ankle, knees were quite swollen tender, but only peculiar finding which was not there was the TLC was very low at 3.5. Although his ESR CRP had improved from what it started, but still the patient on high dose steroids developing a low TLC was a little unusual. It's possible infection, it could be possible something else. So since it was seronegative, again we had a learning point. For seronegative with any leukopenia, always get a CT scan done before you start the patient on any DMARDs or any steroids. The CT done showed me multiple lymph nodes which were present over the pre-paratracheal mediastinal, retroperitoneal, and axillary nodes. And we did a biopsy for him, and it turned out to be a large B cell lymphoma. So it was a very young boy presenting with polyarthritis, and eventually turned out to be a B cell lymphoma. The peculiar points which we need to see if the patient is not responding well to the steroids, he may not be responding well to DMARDs as well. And leukopenias, again, you need to be sure that there's not something missing. So seronegative arthritis is something which we are very careful about still. Because I had one patient she was 6 7 year old, she came with a strong ANA, but her arthritis improved, but her symptoms did not improve completely. She kept complaining of pain near the hip area. And 3 months later, we did an MRI, we found it was a neuroblastoma for them. So carcinomatous polyarthritis is a condition. It can mimic as an oligol polyarthritis and associated with breast, lung, ovaries, and hematological malignancy. You don't need to treat these patients. You treat the malignancy and it gets taken care of. Especially the younger age groups and the older age groups who are seronegative, you should suspect, you should at least look for it. It definitely may cost a little more for the patient, but at least you'll be thorough on your side that way. And this is a very classic picture of RS3PE syndrome, the remitting seronegative symmetrical synovitis with pitting edema. This is very typically seen in CA lung patients or the obese patients as well. So take home messages, arthritis is just not limited to the joints. It's just a sign that yes, there is something which is dwelling underneath. We need to take a proper history. We need to be right approach in our advising the blood test, and properly we need to start the patient on medications. Lot of times crucial time can be lost when we run after some other like positive RA factor or anti-CCP, and it could be some lupus which is hidden inside and it tends to flare up over time. So a good history will definitely lead us there. Blood test should have a very good why we are advising the blood test so that we don't get misled by the same. And it should always be looked at. If patient is still not responding at 4 6 weeks of treatment, definitely relook at the diagnosis, definitely relook at the investigations again, that something else may be dwelling inside, or is it some poor response to our DMARDs? And early recognition and initiation are the key. As we saw in few of the cases, some of them could have been diagnosed early, we could have salvaged the kidneys for them. And that way, this is a very important. And examine the patient as a whole. So I think over 5 to 7 minutes, A brief history and physical examination can help us narrow down the diagnosis there. Thank you.
Thank you, Dr. Naval, for the wonderful presentation. And now we are inviting any questions if there are any. Any questions from any of the delegates? They can unmute themselves and ask any question directly. I think there is no question. Probably rheumatology was the topic in our PG days, which was probably the most difficult topic. And usually students used to avoid these topics. But definitely the presentation, like Dr. Naval's presentation, makes it quite easy. A syndromic approach to rheumatic patient is always important, and careful history taking and examination with the judicious investigation probably clinches the diagnosis. And if we are on mark with the diagnosis, then probably the treatment is not very, very difficult. Dr. Naval, I would like to ask one question.
Yes,
Sir,
sir.
sir, some uh, light on overlap syndromes.
So overlap syndromes definitely are one of the most tricky ones. And a lot of times we tend to put one is the MCTDs, which comes as an overlap of the three, four diseases. But definitely MCTD is only labeled because of the antibody, which is the U1 RNP,
Yeah.
SMRNP. But overlap, then also we try to delineate which is the predominant MCTD which is there, or which is the predominant overlap syndrome which is going through. Still, the most common overlap is the rheumatoid arthritis with the Sjogren syndrome. And second most common which we see is the scleroderma and myositis. So it's always best when we delineate that which organ is involved in which disease, and accordingly we have to figure out our DMARD therapy for them. If the lungs are getting involved, be it scleroderma, myositis, at least we have the right approach. Problem comes when rheumatoid arthritis starts developing ILD. That is when the approach starts to change a little. Was this
Yeah, yeah. Thank you, thank you. And a word about anti-nuclear antibodies by fluorescent immunoassay method. How to read it, and there are different patterns like speckled or other patterns. So how to read them, and how to investigate them further if the patient is ANA positive by FIA.
So normally there's a like in DRA also we did a lot of class with Dr. Ajay. He had explained quite a lot of patterns. But basic for ANA, if ELISA is definitely much more sensitive. But a lot of times we miss out on ELISA the basics. So we normally get the immunofluorescence done. With immunofluorescence, the readings are 1 plus, 2 plus. A lot of labs have a different value. So just simple 1 plus homogeneous is something possibly which is a false positive. A lot of thyroid patients and other patients can have just a false positive ANA as well. Coming that to 2 plus, and we do find a change of pattern, maybe core speckled, maybe a centromere. So these are all pathognomic patterns. Like these are indication of like underlying scleroderma. So further going to 3 plus, that is more significant. Now 3 plus with homogeneous, again, more points, it more be going towards the lupus or maybe towards the mixed connective tissue diseases. So there's a nuclear and the core granular, and that's what we have to see when we see it through the microscopes with them. So normally we do get an ENA done, but definitely we only advise if the patient is 2 plus or 3 plus positive. Not at the 1 plus, we tend to ignore it.
Thank you, sir. Thank you. Any other questions from anybody? Dr. GS, sir? So if there are no more questions,
No question, Dr. Mohan. It was a very nice presentation. Excellent.
Thank you. Thank you. If there are no questions, I would request our secretary, Dr. Soni sir, for the thanks.
Yeah. Thank you, Dr. Naval, for a nice presentation. It was clear to everybody, so there are very few questions. That is why. So, thank you for a nice presentation. Thank you, Dr. Pawan, for continuing the weekly talk. Thank you to the participants. I hope we can spread the message and get more participants next time. Thank you.
Thank you, sir.
Thank you, Dr. Soni sir. And next session would be on body fluid analysis by Dr. Gajendra Yadav. Good night. Good night, everybody.